this lecture in next 30 minutes or so, we will try to discuss a simplistic approach to interpret the arterial blood gas. So outline of my lecture is just introduction about what I'm going to do and the steps of actually interpreting blood gases, and we will do at least about 2 cases if the time permits. Right. So this lecture, when we talk about the arterial blood gas interpretation, I mean the extent of which that we can discuss is enormous. So many things to discuss, and actually the things that is tested in this sort of a topic in your exam may be slightly different from clinical practice. So what I'm trying to do is give you certain skills and the details where you can get a insight into how to clinically interpret a blood gas. So you need to read a lot more, and if you want to sort of answer an exam question based on arterial blood gas, and it's beyond this lecture. And then at the same time, because you guys are registrars, just wanted to tell you that there is a difference between reporting versus interpretation. So I'm actually highlighting this issue at the inception. Reporting is, say, for example, you do a blood gas in a patient, and then you will say, I have done a blood gas, pH is 7.2, carbon dioxide is 70, PaO2 is 60, bicarbonate is this and that. And you know that the listener on the other side of the phone or at the bedside cannot actually manage a patient by just hearing to that, because that is just a reporting of a blood gas and its values. Interpretation is slightly more different. With interpretation, you should be able to manage the patient. So therefore, it's not only just telling the parameters of the blood gas, maybe deranged, maybe normal, but of course, synthesizing and intermingling it with the clinical picture. So interpretation is not just looking at the blood gas report and its values and their derangements, but of course, it's a and correlating them with the clinical picture as well. So throughout this lecture, we are actually trying to highlight this issue of reporting versus interpretation. Okay, so anatomy of a blood gas report. I think almost all of you must have seen a blood gas report, and the blood gas report varies with the blood gas machine, and this is the blood gas machine we have, and you can see there are many parameters available, and mind you, only some of these parameters are actually clinically useful, right? So these parameters, again, I have to say that depends on the machine, and some machines are very basic, so they will give you only few of these parameters, but some machines are advanced. So they will give more parameters. And if you look at the blood gas, the first thing is that these parameters are arranged into two areas, and the first area is actually limited to measured parameters. So of course, some of the parameters are actually measured by the machine, and you can see that the next group is actually calculated from these measured ones. So you need to know whether these are actually a measured ones or calculated ones. Say, for example, a classical example is now I don't know whether I can show it in this blood gas. Yes, you can. I can. Now you can see the saturation here is actually a measured one. So this blood gas machine actually measures saturation. But in most of the blood gas machines available in Sri Lanka, this is of course a blood gas machine in Sri Lanka, but most of the blood gas machines, the saturation will come here, because the saturation is a calculated parameter based on PaO2. So in that circumstance, your saturation here depends on the PaO2. So it might not actually be the correct and actual saturation, because the machine actually put it into an algorithm based on oxygen dissociation curve, and then actually calculate the saturation. So basically, remember, there are two groups of parameters. Some are measured and some are calculated, and it's interesting to know which one is which. Then the other at the same time, I need to tell you that whenever you trying to interpret a blood gas and then manage a patient using the blood gas, or depending on the parameters of the blood gas, so remember that these are tests, and like any test, there could be problems of accuracy. So accuracy could be because of a sampling issue. Say, for example, you try to sample, and if you want to sort of prove yourself that you can do a blood gas, but actually you are unable to. Sometimes what happens is you take drops of blood into the blood gas syringe and then put it into the blood gas machine. And we have done this as trainees when we are pressed to according to the clinical situation, and we have seen this the trainees are doing. So if that is the case, actual values that you get might not actually correct, because there may be a lot of interaction with the environment when you do that. And then the transport, you have to use this blood gas as soon as you sampled, or you have to store it in a in appropriate way. And also it depends on the machine. Now, if in this example, you can see that there are a lot of question marks, and it's a UC is uncalibrated. So whenever you see this, the values may not be actually accurate. Right. So interpretation of blood gas, like in any other critical care approach, has a structured approach. So if you look at different books and different lectures, and look into different people, and they may be saying different steps, but this is how I usually teach. So I usually advocate 7 steps. So the first step of looking at a blood gas is looking at the pH. So remember, pH is a measured parameter. So the second thing that you after looking at the pH is if the pH is deranged, who causes this derangement. So to do that, you need to look into carbon dioxide, bicarbonate, and the base excess or base deficit. Then thirdly, when you establish that there is a derangement in the acid-base status, the third thing that you need to look into is whether there is any compensation, and we'll come to that in next coming slides. Then fourthly, if there is a problem, you try to do certain things using the blood gas itself mostly, or using other investigations to narrow down your differential diagnosis. So say, for example, metabolic acidosis, you try to calculate anion gap and see whether your metabolic acidosis is non-anion gap metabolic acidosis or high anion gap metabolic acidosis. So your differential diagnosis is narrow if you can come to a conclusion. And for metabolic alkalosis, you might calculate urinary, you might measure urinary chloride, and depending on the urinary chloride, you can classify it into either chloride responsive or chloride resistance kind of metabolic alkalosis. Then the fifth step is actually take all these things and have a acid-base diagnosis, complete acid-base diagnosis. And sixth, and some actually advocate this as the first step. So you need to look at oxygen and other parameters. So out of the other parameters, I think oxygen and its surrogates are one of the most important parameters in a blood gas sheet. Then last but not the least important step is to arrive at a clinical diagnosis. So to do this, you have to have a acid-base diagnosis, and you need to look into the other parameters, including oxygen, and also you need to know certain things about the clinical background and the current clinical picture of the child or the adult or the patient. Right. Okay. So let's go into these steps one by one. And before I look into the first step, usually you do a blood gas to find out something. I mean, you won't just do a blood gas and see something and then try to act upon it, but you do it with a purpose. So you should know the clinical background, why you are doing it, and what you are looking for, so what you are expecting before getting into any of these structured steps. So first step, you look at the pH. So depending on the pH, you could get either a normal pH. You can get pH less than 7.35. We call it acidemic pH, or you can get a value exceeding 7.45, and we call it alkalemic sample. But remember, so if the pH is less than 7.35, some call it acidosis. And if this is more than 7.45, some call it alkalosis. But I think the actual or the correct term is acidemia and alkalemia, depending on the pH. And there is a reason why I'm stressing this, because a patient could still be acidotic or alkalotic without being acidemic. Say, for example, a person who is acidotic can have normal pH, and I will come to that in next couple of slides. So the patient is actually having an acidosis, but is not acidemic. So understanding these terms is therefore very important. So the second thing, if you have any issues with the pH, is to identify who is causing this. And to do that, you look at carbon dioxide, you look at bicarbonate, and you look at base deficit or base excess. And normal carbon dioxide, as you know, is between 35 to 45, and anything above 45 is hypercarbic. And we know that if a patient is hypercarbic, you need to look into DOPE as minimum. So DOPE is dislodgement, obstruction, pneumothorax or equipment failure, and this is for a ventilated child. Or the patient may be hypocarbic if it is less than 35. And in certain interpretations, rather than having a range, and you will get a one value or the cutoff point. And if you are taking a cutoff point for an interpretation, cutoff point would be 40. So in that circumstances, anything below 40 is hypocarbic, anything above 40 is hypercarbic. Then bicarbonate. The normal range is between 22 to 26, and depending on the textbooks, this may vary slightly, and it's not very important. And the base deficit, what is inside these parentheses are actually base deficit. So base deficit or base excess has a range. It may be from +2 to -2. So this is the normal range. And hypercarbia is when it is more than 26, or when the base deficit is more than 2, base excess or base deficit is more than 2, base excess is more than 2. And when it is less than 22, bicarbonate is low, and in that circumstances, the patient will have a base deficit. So just to tell you certain things about this base excess and the base deficit and the bicarbonate. And if you look at the blood gas report here, so blood gas report, you can see base excess is expressed as base excess ECF and base excess blood, and bicarbonate is expressed as standard bicarbonate. SBC is standard bicarbonate and actual bicarbonate. So let's look into what these terms actually tell you. So what is base excess? So base excess is the amount of strong acid that must be added to each liter of blood to return the pH to 7.40 at standard conditions. So base excess means there is more base, so you need to add strong acid to get the pH back to normal, and the definition usually expressed at standard conditions. And what are these standard conditions? When the blood is fully oxygenated, where the saturation is 100% and the PaO2 is around 100, and when the temperature is 37 and the carbon dioxide is standardized to 40. So so that is what we call the base excess. Base excess. Then base excess blood. And what are base excess ECF? So base excess blood or actual base excess is the base excess as it explains. But base excess ECF is this. Now, when we talk about base excess, we said amount of strong acid that must be added to each liter of blood. Now here, rather than each liter of blood, you take each liter of extracellular fluid. So that is what is meant by base excess ECF. Why there is a difference? Because extracellular fluid has two components in it. So it has blood or intravascular component as well as interstitial component. So why there is a difference? Difference is from the presence of hemoglobin. Now, when you talk about blood, there is hemoglobin concentration is high. Remember, hemoglobin is a buffer. When we talk about ECF, now hemoglobin is concentrated in the intravascular component, but there is no hemoglobin in the interstitial space. So when we talk about the base excess ECF, blood gas machine even out this hemoglobin, which is available inside the intravascular compartment, throughout the extracellular compartment. So usual algorithm is that it will assume when this occurs, the hemoglobin is about 5 grams per deciliter. So you may be having hemoglobin of 10 grams inside the blood, but if this blood is actually distributed all over the extracellular fluid compartment, then the machine assumes that the hemoglobin is about 5 grams, and then it calculates the base excess ECF. So this is what we call the base excess ECF. So these two will have slightly different values therefore. And bicarbonate, I said there are two ways of expressing standard bicarbonate and actual bicarbonate. And standard bicarbonate is bicarbonate calculated. Now bicarbonate is a calculated value, and standard bicarbonate is bicarbonate calculated whenever there is standard conditions. So what are these standard conditions? When the carbon dioxide is 40 and when the oxygen is 100 and when the temperature is 37. And actual bicarbonate, as the name implies, it's the actual amount of bicarbonate without correcting it for the standard conditions. Right. So so if you have look at the pH, 3 possibilities. It could be normal, it could be acidic, or it could be alkalemic. Then you looked at the carbon dioxide and the bicarbonate, and now you should be able to tell if the pH is deranged, who is causing this derangement. Say for example, if there is acidosis, and when you look at the carbon dioxide, if the carbon dioxide is high, then you know that that is a respiratory acidosis. And if there is alkalosis, and when you look at the bicarbonate, if the bicarbonate is high, then you know that it's a metabolic alkalosis. And at this moment of time, it's important to tell you the third possibility. And sometimes you may have a normal pH in the blood test. So just don't ignore the other parameters if the pH is normal, because a normal pH can occur in the presence of two abnormal processes. And this is what I explained earlier, why the definition of alkalemia and acidemia as opposed to acidosis and alkalosis is important. Say for example, if a patient is having a metabolic acidosis, which is balanced by metabolic or respiratory alkalosis, then the patient potentially can have normal pH but very abnormal bicarbonate and the carbon dioxide. So even if you see normal pH, don't just ignore carbon dioxide and bicarbonate. Always look at the carbon dioxide and bicarbonate. If the bicarbonate and the carbon dioxide both are normal in the presence of normal pH, you can put it down as normal. But if these two are abnormal, if one of these is abnormal, you know that the other one is also abnormal. It has to be abnormal, and then you have two opposing processes rather than having a normal pH. And at this moment of time, and we'll come to that later on, just wanted to highlight that a compensatory process will never ever make the pH normal, right? So that is the current consensus of most of the authorities in blood gases. Right. So let's talk third step. So first step is look at the pH. Second step is looking at the carbon dioxide, bicarbonate, and base deficit. And the third step is looking at the compensation. So remember, any respiratory abnormality will be compensated by a metabolic process, and the metabolic abnormality will be compensated by a respiratory process. Say, for example, patient is having a metabolic acidosis. Now pH is deranged, so pH has gone down. Now the body is trying to get the pH as normal as possible, and to do that, the patient's respiratory drive will increase, so respiratory rate will increase, depth might increase, and that will cause the washing out of the carbon dioxide. So ultimately pH will be nearly normalized, not completely normalized. Again, I'm highlighting that the compensation will never ever normalize the pH. So so remember, respiratory acidosis is compensated by retaining the bicarbonate, alkalosis by eliminating the bicarbonate, and metabolic acidosis by washing out the carbon dioxide, and metabolic alkalosis by keeping the carbon dioxide. And usually metabolic processes will be compensated quite quickly, because the respiratory system is very efficient in washing out carbon dioxide or keeping carbon dioxide. But the respiratory process will not be compensated that rapidly, because kidneys take some time either to retain bicarbonate or eliminate bicarbonate. Right. So in this patient, this is what I highlighted earlier. Now you can see the pH is normal 4.5, and the carbon dioxide is 70, and the bicarbonate is 48. So this patient, although having high carbon dioxide and high bicarbonate, has normal pH, because these are two opposing disorders. So this patient is having a mixed disorder. This patient is having respiratory acidosis and metabolic alkalosis, rather than either respiratory acidosis compensated by metabolic alkalosis, or compensated by metabolic process, or metabolic alkalosis compensated by respiratory process, because the pH is normal. Right. So when we talk about compensation, normally we don't use these formulas in clinical practice, but there are ways of calculating expected compensation. So if the patient is not having expected compensation, you can say that there is an additional process going on. And for metabolic acidosis, this is the formula, and for metabolic alkalosis, this. And there are different formulas for respiratory acidosis and respiratory alkalosis, as well as these formulas will differ each process into acute and chronic. And this is actually called 1, 2, 4, 5 rule as well, because you can see that there are factors of 1, 2, 4, and 5. So I'm not going to sort of go into details about this, because this is very confusing if I try to explain this within this short time period. But see these and go through these and see whether you can work out how these things are calculated. Now I said earlier, in certain situations, you take cutoff point than the range. Now, this is a situation where you take the cutoff point. Now, this 40 is actually the carbon dioxide. So this is the cutoff point, and this 24 is the bicarbonate level. Rather than 22 to 26, you have get the cutoff point of 24. So these formulas actually using cutoff points rather than reference ranges. So go through these and they try to work out expected compensations, and you might use this in couple of blood gases that is from your unit whenever you go to the unit and see how you can use it, but largely these are not very relevant in clinical practice. Rather, this is very relevant in clinical practice. So this is the fourth step. Whenever you have metabolic acidosis, then you need to calculate the anion gap. So anion gap is actually sodium minus chloride minus bicarbonate, and range is 8 to 16, and again the cutoff point is 12. And usually when we talk about high anion gap, usually you have anion gap more than 20 is usually, and normal anion gap is anything between 8 to 16. So your anion gap acidosis can be classified into high anion gap and a normal anion gap. So there are some examples here. I think there are many ways of remembering this high anion gap and the normal anion gap, and one of the ways is to apply the neodymium multiplies for high anion gap metabolic acidosis. And how you get anion gap is explained by this picture, and you can see this is normal plasma, and this is the major cation, which is sodium, and there are certain major anions. So these are the ones that we normally measure, but there are certain things that we don't measure. So ideally your anions should match the cations, but because the differences between the measured ones and the unmeasured ones, you get this difference. And this is an example for acidosis with no gap. So there is no gap here, and there is an acidosis with a gap. You can see. So this is the normal, and this is again there is acidosis, but there is this gap is normal, and here this is a high anion gap metabolic acidosis. So there is a significant gap, and I hope you can understand this physiological picture by looking at this graph. Sorry. So when we talk about anion gap, there is another term usually expressed in physiology books, and this is called a delta ratio. And delta ratio is actually the ratio between the change in the anion gap. So normal anion gap is considered as 12. Again, a situation where you take the cutoff point rather than the reference range. So change in the anion gap from 12. And this is only for the high anion gap metabolic acidosis. So say if your anion gap is 25, so your change is 13, and the change in the bicarbonate, again you take the cutoff point as 24 in this situation. So normal bicarbonate is 24. So depending on the situation, you can get certain values, and usual range is between 1 to 2, and if it is more than 2, there is high anion gap acidosis with pre-existing metabolic acidosis. So if this is slightly lower, so there may be another type of metabolic acidosis in addition to the high anion gap. Right. So then for the metabolic acidosis, I said you need to look at the urinary chloride. So it could be less than 20 or more than 20. So you can refer to any standard textbooks to get conditions. What are the conditions who has less chloride responsive metabolic acidosis, and who can get more chlorides. Then the fifth step is, as I said, to have a acid-base diagnosis. So whenever you have acid-base diagnosis, there are certain components that you need to include in it, and what sort of acidosis and the severity, whether there is a compensation, anion glycochloride, depending on the type of derangement, chronic or acute in case of respiratory. So example, severe high anion gap metabolic acidosis with respiratory compensation. Right. So sixth step is on oxygen. So there are many ways that that you can get an idea about oxygen in the blood gas, and one of the simplest ways is look at the PaO2. But always look at the PaO2 in the context of FiO2. That is, if you know the FiO2. So which means that you are referring to PF ratio than just the PaO2, because I think you already know that your PaO2 will depend on the FiO2. So you can have the same PaO2 with less FiO2 and high FiO2. So if you don't look into the amount of oxygen given to achieve that PaO2, so you might get you might see a result which might not actually reflecting the patient's clinical picture. Then you might have a saturation, and this is usually a calculated value in most machines, with some exceptions. So this will really depend on the PaO2. And then you have what we call the AA difference and AA ratios, and we will come to that in the next slide. And also you can have surrogates of oxygenation like lactate. Right. So when we talk about oxygen, remember that there are certain things that you need to realize, and there's a thing called oxygen content in the blood. So oxygen content has two components: oxygen attached to hemoglobin, oxygen dissolved in the blood. Actually, the PaO2 only give you an idea about dissolved hemoglobin. So dissolved hemoglobin carries less oxygen comparative to oxygen attached to hemoglobin. And also very important to realize that oxygen is meant to deliver to the tissues rather than be there. So you can have good oxygen in the blood, but still your tissues might starve. So whenever you look at the blood gas, remember you need to look into the oxygen delivery and also oxygen utilization as well. Say, for example, you will try to increase the ventilatory settings, ventilatory pressures to achieve good oxygen in the blood, but this will actually reduce the venous return and reduce the cardiac output as a result. So you will have good amount of oxygen in the blood or adequate amount of oxygen in the blood, but because of the reduced cardiac output, this might not get delivered to the tissues. So hypoxia versus hypoxemia. So hypoxia is actually less oxygen in the tissues, and hypoxemia is actually less oxygen in the blood. So PaO2 versus actual tissue hypoxia. And in the blood gas, we normally measure the hypoxemia. So there are several ways of measuring hypoxemia. It's by looking at the PaO2, PF ratios, AA difference, AA gap, and what we call respiratory index. So AA gap is arterial oxygen tension divided by the alveolar oxygen tension. Respiratory index is the AA gap divided by PaO2. The difference between these two from AA is that these two is less affected by FiO2 and the barometric pressure. So it's less change, but in clinical practice, none of these three are important. Right. So just to highlight of some errors that you might get into whenever you look at these values. So these are gases of a patient, and on admission, arrival at ICU, and after intubation. So just look at few things. You can see the PaO2 has consistently improved, and FiO2 of course has gone up, and carbon dioxide almost the same. And because the FiO2 has gone up, and you can see that the PF ratio initially has increased, so which indicates that to the amount of FiO2, PaO2 is higher rather when we compare on admission to the intubation. But look at this A gradient. So A gradient has increased. So if you just look at the A gradient, you might think that this patient is worsening, but this patient is not actually worsening. This patient is really getting better, or maybe at least the same. If you look at the respiratory index, it's almost the same because these doesn't get affected by the FiO2, and the A ratio again remains the same because it is not getting affected by the FI ratio. And the reason why this A gradient has increased is because of this FiO2, and also this A gradient can be affected by the carbon dioxide as well. So remember, whenever you look into these parameters and think about the other things that can affect their value. So seventh step, which is the most important, and which is the interpretation of all these values, synthesizing with the clinical picture. And this is very important if you want to treat the patient rather than the ventilator or the blood gas report. So seventh step is one of the most important steps from 1 to 7. So I discuss this. And if you want to study more on the blood gas, I think there are 2 free important websites, and one is Life in the Fast Lane. I hope you all know about this. And one is the Deranged Physiology. And these will explain certain things according to previous exam questions. So these exam questions are basically critical medicine kind of exam questions. So and out of the blood gases, they will identify the exam questions that were targeting this blood gas topic, and they explain certain things using that. So these two are very good blood gas report. And there is an article, if you put interpretation of arterial blood gas results plus BMJ in the Google search, you will get this article. It's a good article. And for emergency medicine, there is a website called EMCRIT that is also a good site to further study blood gases. So just to highlight what I told you in 2 cases. So the first case, 6-month-old pneumonia patient on high flow oxygen, and who is on 2 liters per kg of oxygen with a FiO2 of 90%, and heart rate is 170 and respiratory rate is 60. And if you look at the blood gas, you can see that the pH is normal and the carbon dioxide seems to be normal. And PaO2 is 90, and the bicarbonate is 24, and base deficit is -1. So if you, I said, whenever you look at the blood gas, whenever you are doing a blood gas, think about the clinical picture of the patient and think what you expect in this patient. So this is a 6-month-old pneumonia patient on high flow, and the patient is having a very high respiratory rate, which means the minute ventilation is high. So you expect these patients to have a kind of alkalotic picture, because they normally wash out carbon dioxide. That's the normal picture in pediatric patients. So in this patient, in this patient, pH is normal, carbon dioxide is normal, and PO2 seems to be normal. But if you look at the PF ratio, it's about 100. So low PF ratio, and you expect this child to have alkalotic pH, but this child is not. So you will be very worried about this child, because this child may be having impending respiratory failure. So you need to go and evaluate this child again about impending respiratory failure based on this carbon dioxide alone. So remember, when you evaluate the respiratory distress in a child, you look at 3 things. One is the effort. So this child is having high effort. Next thing is the efficacy. So efficacy is what you expect from this high respiratory rate and the respiratory distress, which is not there. And the third thing is the effects. And you can see that effects of this respiratory failure is already starting. Heart rate is high. I haven't given the other parameters here. Okay, case 2, 2 months, poor feeding for 1 day. And this is the heart rate, and this is the blood pressure. And looking at the hemodynamic parameters, you can see that this child is in a kind of compensated shock. And when you look at the blood gas, acidotic and bicarbonate is low, and the lactate is 5. So acidemic pH, and who is causing this? This is the metabolic acidosis. And whenever you have metabolic acidosis, you need to look at the anion gap. So anion gap is 20. So which means you have to look into mud plies and look at the lactate. Lactate is high. So this patient is having lactic acidosis, and which is compensated actually with reduction in the carbon dioxide. So this patient is actually having compensated shock, or most likely sepsis. So requires cardiovascular support. Right. So that reaches to the end of this lecture. So in summary, whenever you do a blood gas, do not treat the blood gas, but treat the patient. So know why you are doing the gas and think of the expected findings. And to do this, you need to have a blood gas interpretation together with clinical correlation, and have a structured approach. Because if you have a structured approach, you won't miss certain things. And also remember that many things can change the blood gas. So you can have sampling errors, you can have machine errors, etc. So always compensate for these things. Thank you. Yeah, so I will answer a couple of questions. One question is how accurate venous PCO2 can be when you used it in calculations comparative to arterial PCO2. Whenever you use venous carbon dioxide, you should know that it can change from about 5 from the arterial gas. So when you take it as a single value, it might not actually reflect the actual picture. So don't replace arterial carbon dioxide with venous carbon dioxide if you're just looking at a single value. But if you want to sort of do serial things and then see the serial changes, of course you can take you can surrogate arterial carbon dioxide from